Yes, we presented here at ASH 2021 the results from CARTITUDE-2, Cohort B. In this specific cohort, we enrolled patients with an early relapse after frontline therapy. So patients could be enrolled if they had relapsed 12 months after autologous stem cell transplantation or 12 months after starting PI-IMiD-based induction therapy if the patient did not receive a transplant. Patients that relapse within 12 months have a very poor outcome. They have a survival of approximately 2 years, maybe even less. So there's an unmet need for better therapies to improve their survival. And in CARTITUDE-2 Cohort B, we enrolled 19 patients with early relapse. Most of these patients had received a prior autologous stem cell transplantation, and we treated these patients with Cilta-cel. So Cilta-cel is a BCMA targeting CAR T-cell product, and it has two binding sites for BCMA, which confers high avidity. So it binds with very high power to the tumor cells, and that may explain parts of its potency. In the study, patients were screened and then they underwent lymphocyte apheresis. The lymphocytes were sent to the laboratory to manufacture CAR T cells, and before these CAR T cells were given back, the patients received fludarabine and cyclophosphamide conditioning, and then the CAR T cells were given, and then the patient was observed in the hospital or even as an outpatient directly thereafter. So when we look at the results of these 19 patients that were treated with Cilta-cel, I think the results are very good. There was a 95% overall response rate and a complete remission rate of 80%. With a median follow-up of approximately 11 to 12 months. So very deep remissions, and we know now that also progression-free survival looked very promising, because at 12 months the PFS rate was 80%. So after 1 year, 80% of the patients were still alive and free of progression, and that of course compares favorably to the results that these patients had up front during first-line therapy, because these patients all developed progressive disease within 1 year. So I think we can already conclude that CAR T-cell therapy is a very effective therapy for patients with aggressive early relapse. Regarding toxicity, I think overall the toxicity profile looked favorable. We saw cytokine release syndrome, which was manageable. We saw cytopenias, which can be seen with most CAR T-cell products. But there was one patient with a movement and neurocognitive treatment-related adverse event. These events are currently rare in the CARTITUDE program because of the new management strategies that have been implemented. But this patient had multiple risk factors to develop movement and neurocognitive treatment-related adverse events. That is, he developed cytokine release syndrome. He had massive expansion of CAR T cells. He had also a high tumor burden before the CAR T cells were infused, and he also had progressive disease, in fact, during bridging. So he had multiple risk factors, of which we know that they predispose to this symptomatology. He was treated with steroids and cytokine blockers, and at the time of the data cutoff, his symptoms were improving, and he had achieved a complete remission, while he was very refractory during upfront therapy. So overall, I think we can conclude that Cilta-cel for early relapse is promising, with a high response rate, including 80% complete remissions, with a favorable toxicity profile. And thereby, I think it's a good drug for people with aggressive early relapse. And these patients, again, have a high risk of early mortality because of the aggressiveness of the disease.